When I examine the breast of a patient, first of all, the thing I emphasize to a patient is that the breast tissue is not just the breasts. It's really, if you can imagine, the area above the clavicle, down across the chest, down the chest wall, across, and then into the axilla. And it's really important that you consider all that part of the breast tissue. And the first thing I'll do is I'll have the patient assume different positions designed to try and pull out anything that may be asymmetrical or abnormal in a particular patient's breast. So we put the patient through different range of motion, putting the hands against the hips with the chest wall, lifting the arms up, putting the arms behind the head. And what you're doing when you're doing all those things is you're trying to create tension on the breast that is going to bring out any asymmetry. Now, very important, of course, to ask a patient if any asymmetry that's there before you do anything is normal. A nipple that seems to always be retracted, a breast that's larger than another breast, or any lumps that may have been there for a long time. So that may account for asymmetry. But when you do this, for example, pulling the breast through tension, what you may see if there's a breast cancer, the breast cancer tends to stick to the chest wall because it interdigitates really into the tissue. And so what it's going to do is it's going to pull down and you'll get a dimpling effect. And anything of that sort really needs to be checked immediately. That's a concern. Also, when I'm checking the breast, I'll check the nipples and check for discharge, for example. And they describe 3 different ways of actually checking the tissue. First of all, you use this part of your hand because this part of your hand is the most sensitive, firmly against the chest wall or the breast, and you go in circular motions. And you can go in circular motions either around from the nipple outwards, almost like a spiral. You can go right, or you can go. Oh hell! Or you can go. You should probably better if you're facing them. Yeah. So you can go into. So in a spiral region way out this way, you can go as though you're going through the spokes of a bicycle. And the way I happen to prefer, you're going in spiral motion, in circular motions, but you're going back and forth across the lay of the land, if you will. So this way I feel you don't miss the corners as you might with the other.
One thing I would interject at this point, sometimes patients will be talking to you during the examination. This is the one time. We're very social, as you can see. But that's the one time that I ask the patient not to talk. Because, in fact, I try and picture what's below my hand in my mind. And so if someone's talking to me or being social, I'm not really concentrating. And I think that's important.
I close my eyes, actually. I close my eyes as I'm examining, because I do that also when I'm listening, especially when I'm listening to a baby crying and I'm trying to listen to a chest. I close my eyes so that my focus is really on what I'm doing. There is one other time, by the way, when you shouldn't talk, and that's when the blood pressure is being taken. Anyway, that's the way the breast should be examined, and it should take. It shouldn't be done in 3 seconds. It should be. The doctor really needs to cover all zones, and you should cover all zones. It's true that women tend to find their breast lumps more often than we do, or they're the first ones who come. Although there was, when you talk about the recommendations and task force recommendations, even though I've been teaching breast self-exam for years, I think it was 2 or 3 years ago that task force came out and suggested not doing it because a lot of false positives were being picked up. I'm not sure how I feel about that.
I feel the best person to know that the patient is breast. Yeah, I think. And also, one thing I mentioned to the patient is, as I'm doing an examination, as they're sitting up, I'm making a mental note, and I have a picture of the breast. I will not say that I feel something. If someone says they have a lump on their right breast, I'll always examine the left breast first. And I'll always do the side that's not affected to kind of compare it in my mind. When I asked the patient to lie down, in my mind I said, well, I did feel something at 3 o'clock at the left breast. I'm going to do that last, and I'll start at the other side, and then I'll draw a picture. And having a picture of the topography of the breast is very important. We draw it, we make a mark, and then we ask if an ultrasound can be done, a thermogram. I do thermograms as well as mammograms. Investigation in our office for a menopausal patient will include include, I think you mentioned, did you mention bone density, bone densometry?
I do bone densities actually at that stage as well.
And now we're doing one more thing. We're going to do what's called a continuous patient profile. On the back of my sheet, what I will do is I'll do a flow sheet, and I'll have the patient now begin to record when they do have their testing. Sometimes I'll write down a different color the date of a pap smear, because the patient may not remember that a pap smear, and I want to remember that. Pap smears, doctors are tending to do every 2 years, every 3 years in menopause. Once again, a little iffy, because if you ask a patient to come every 2 or 3 years, and that's the only time that you do a gynecological assessment, you miss breast examinations. So I think it's important, even a person with a hysterectomy should have an internal examination, especially if their ovaries are left. I do a CA-125, the same as Amanda does a PSA. I do it once a year. Normal levels under 35. I think it's a good screening test. It's not just accurate for ovarian cancer, and that's why I don't necessarily do it when someone's menstruating, because you can have an elevated CA-125 with fibroids and endometriosis and a lot of benign conditions. Anything else, your thoughts on that?
No. No, I mean, and we don't, I mean, there's something, for instance, I don't routinely do CA-125s. My concern about the CA-125s is that they're very sensitive but not very specific, and there is an issue with that. And we don't necessarily always agree on everything here, and I think that's the beauty of medicine. But the real beauty is that we can still dialogue, and we can still, you know, collegial about the reason I'm concerned about CA-125s, as I said, is because you get a lot of false positives. And I'm not going to go into a whole story, but you know, I've had patients who've insisted, you know, unfortunately Gilda Radner, when she before she passed away, too often I think diseases are celebritized, and she went around saying everyone should have CA-125s. And as I said, it's not very specific, it's highly sensitive, and the question is, what do you do if you get a positive one? You know, there have been some, there was at least one study that suggested that for every 100 women that you get a positive CA-125, if you wanted to definitively see if they had cancer, ovarian cancer, you'd have to do a laparotomy. And out of the 100 women, you'd find one woman with ovarian cancer. So there is a concern with doing these things, because you could be creating a lot of morbidity. So I think it's important, and I think really the message is that anything you do in discussion with your doctor, and you listen to the pros and cons, and you make the decision as a team.